Well, talking about iris supported, here I'm going to talk about posterior fixation of iris supported iris clip lenses. And I'm sure, like the beautiful techniques that were shown before, this is also one of the things every cataract surgeon must know, and it's very easy to know it, and it's very quick. The reason being, very often one comes across a time when, well, the PC support is not enough, even for sulcus fixated, and you are mentally not yet prepared to go in for scleral fixated. Scleral fixated requires you to, go through a little bit of more. It's you have to close and then make that sometimes a flap, or all. It becomes the common situation as an emergency standby IOL when PC support is inadequate, as I said, as a planned procedure during IOL exchange during combined procedures along with vitreoretinal surgery. Iris clip IOL is available both for phakic and aphakic situations. Aphakic iris clip when placed on anterior as well as posterior surface of the iris, but presently we only resort to the retrofixation or posterior fixation. It's available as plate haptic or one with vaulting. It is available in a small optic and overall small size, or one with overall size of 9 mm and 5 mm. It needs to be handled carefully to avoid damage to its claws, and before you put it, you have to inspect them, because very often if the claws are not functioning well, you do see a situation where the iris clip just gives way and it hangs with one thing. Let's okay. Now this is a situation. This is a case of extreme case of Marfan's, in which my preferred choice in the past used to be scleral fixated, but of late with the iris clip showing good results, I have resorted to this, and it seems to be working well. I have no personal experience of long-term stability, but in the last 3 years that I have done, these cases have seemed to do well. My preferred technique for Marfan's is I fill the eye with viscoelastic, which prevents the vitreous getting disturbed. You only have to manage to get a small rhexis. Even if the Marfan's is more extreme than this, you can get it. In fact, there are some who prefer, or in the past I used to prefer to fix that back, but presently I don't do it. And at this stage, a dilated pupil necessarily has to come down before you can fix a lens. This is a lens which, if you have to put it in the AC, then you put with those claws posteriorly directed. Here, after you have put the lens, you fill it with viscoelastic, so you have enough space. Then you put 2 sutures, and then with this forceps, which has got a catch, you hold it, get the lens. Either you get it with one haptic down, enclave it, and then go to the other haptic, or sometimes you can hold it behind with both the haptics behind the iris and go through either side port to fix it. Or sometimes you also come across cases where a patient has undergone surgery in the past. Sometimes in a situation like this, where circular pupil is not present or broad iridectomy is done, even in such cases, iris clip has a role. You can always do the iris clip in the manner that I showed before, and after that, you can always use the remnant of iris tissue to do a pupilloplasty and create a circular pupil. That's very important. Not for all, but some people are very sensitive to this edge, and they may complain of edge glare. Of course, edge glare in this situation is not as much, because the upper lid normally covers it. If it's somewhere here or down, I've had cases where after old vitrectomy and for a traumatic cataract and traumatic retinal problem with pupillary traumatic mydriasis, where I had to do one pupilloplasty here and another here. Patient had 6'9", 6'6", but he always complained of that edge glare. So first we covered this, his edge glare went down. 3 months later he came back saying, I'm still not 100% okay. We put a stitch here and he was doing good. After you have stitched those, clean the AC and put pilocarpine, of course, and the pupil is circular and reasonably centered. You also may come across some of your own cases, like this was a case that I had done for a pseudo exfoliation. I do not remember, maybe 7 to 8 years before, where it has resulted in extreme form of capsular phimosis, and the whole bag has shifted. At such times, you have different options. For me, in this case, the option was to get the whole bag lens complex into the AC and make a large opening and get it out. And then, I had the option of doing scleral fixated, but since this is quick and it's easy to do, I resorted to fixing an IOL here, iris clip lens. Now, if you go to the stall, there are iris clip lenses from various different companies. Some have on a design of a phakic IOL where there is a vaulting, whereas others have a plate haptic kind of a thing, which either way you just have to be used to putting a lens. This is the one from one thing is, before you put, you have to look at that claw there, and there's very high incidence of manufacturing defect, because the one company that makes the IOCare, now very often, there's only a couple of seconds, or maybe 10 or 15 seconds. The important thing is, after you have held it, use your second instrument at Sinsky to position it properly. Always the problem in the initial cases is that the lens tends to get shifted down. So once the lens is in, pull it up, center it well, fill viscoelastic into the AC. The AC gets deeper, and it gets deeper around the haptics, so you can identify your haptics well. You can inject viscoelastic just before enclaving, and that helps you identify the haptic and the claws, and then you can do it. And okay, that's fine. I will not show that. This one, you can inject viscoelastic just before enclaving, and that helps you identify the haptic and the claws, and then you can do it. And okay, that's fine. I will not show that. This was I don't want to show, but what happens is sometimes these patients may come. Now this is a classic case of a patient who's undergone iris clip, and the manufacturing defect has led to one of the haptic giving way, but the lens can hang for quite some time with one enclaved haptics. At such times, sometimes you can always re-enclave it if the haptics are not defective.